we are going to be dealing with. We are going to be dealing with clinical and pathology aspects of peripheral neuropathies, and we are going to start with a brief anatomy of the peripheral nerve. Then we will discuss, which I believe is really the most important part of this lecture, is the approach to a patient with peripheral neuropathy, and we will conclude with some distinctive pathological features of some peripheral neuropathies. All right, so peripheral nerves contain bundles of myelinated and unmyelinated axons. So it has both actually, myelinated and unmyelinated axons. And this bundle right here is a good example actually of a nerve fiber that contains both myelinated, as you can see, the one, do you see let's put the other pointer options. Do you see now, this is the ones that are thick, it looks like a dark rimmed, structures. These are the myelinated actually axons. The unmyelinated axons at this resolution, you will not be able to see it, okay? So this actually fiber is stained with toluidine blue to give you this contrast. And at the periphery, actually, you see a fibrous sheath which connects the different nerve bundles together. So the dark rings are myelin sheath, and the light contents inside them are the axons, right? So as I mentioned to you, the unmyelinated axons are not visible at this resolution. And a normal nerve will have many bundles like this, okay? Normal peripheral nerve will have many bundles like this. And the structure in the right upper quadrant right here, this one right here, just 1 second. Sorry. So the structure in the right upper quadrant right here, do you see that? It illustrates a single myelinated fiber. All right, so this is, as a whole, a single myelinated fiber. How is that? So you have actually the dark ring is the myelin sheath right here. The contents inside it, the white contents right here, the light contents are actually the axon. Now, the whole myelinated fiber is, put in a Schwann cell. This is the Schwann cell right here, okay? All right, so the plasma membrane of the Schwann cell, is what makes the myelin sheath, right? Okay, I believe you must have taken that in histology. Let's hope that you did. So the myelin is a Schwann cell membrane. Okay, this is where the myelin comes from, Schwann cell membrane, that are wrapped around in many layers and compacted. Okay. All right, so myelin in the peripheral nervous system, it's made up by the Schwann cells. Now, in the central nervous system, it is made by the oligodendroglial cells. All right, so the picture in the left lower quadrant is an electron microscopy picture of a peripheral nerve which shows several myelinated axons, as you can see here, and several unmyelinated axons. So if you look at this, one thing that you will figure out right off the bat is that the myelinated axons are larger in diameter than the unmyelinated axons. Now remember that all of them, even though those are actually unmyelinated, are embedded in the Schwann cell cytoplasm. They are still within this big Schwann cell cytoplasm. All right. So in terms of size, as I mentioned to you here, the myelinated axons range between 1 and 20 micron in diameter, and they carry the movement, the motor, function. They carry also the sense of position. And whereas the smaller ones, the smaller and myelinated axons carry the temperature, the pain, and the autonomic function. All right. In between them, in between the different axons, the myelinated and unmyelinated, there is an amorphous material. This amorphous material is actually the collagen. All right, so now in the right lower quadrant, you see actually a longitudinal section of the axon, so along the length of the axon, and you can see actually that this axon is wrapped around with with myelin, but this myelin is not continuous. It is discontinuous or interrupted. And that is a very important fact and a very important, feature really of the myelinated axon is that the myelin sheath is discontinuous. And the reason why it is important is because actually the electrical impulse jumps from one node, what you call the node of Ranvier, I'm sure you have heard that before, to the second node, rather than being moving along the axons itself. And by jumping or saltatory kind of conduction, it's going to be actually faster kind of conduction. All right. Now, when you remove the myelin, the jumping method of conduction is going to be gone. And as a result of that, the impulse will be gone and the motor power and the sensations will be gone as well. Okay? So this is number one. All right. So this is for you, if you want to take, if you have taken any notes, it is right here. Okay. All right, let's talk now about an important actually part of this lecture. And that is, the basic reactions, seen in peripheral neuropathy. What happens really when a peripheral nerve is damaged, okay? Or what are, if you want to think about it, what are the patterns really? What are the methods? How do they present, if you will? All right, so the top, of this picture shows you the normal nerve right here. Normal nerve, where you see actually that on the left there is a neuronal body, all right, and on the right there is the neuromuscular junction right here. Between them is the axon with its discontinuous myelin sheath. All right. Okay, so this is the normal nerve. Now, the second in from the top is going to be a special form of reaction known as Wallerian degeneration. So Wallerian degeneration occurs when the axon is transected, as you can see here. Right? So once the axon gets transected, so the proximal to the transection, you will see some degeneration, but it's going to be limited by the node of Ranvier that comes, immediately after the transection. However, distal to the transection, what's going to happen, myelin and axon are going to disintegrate structurally and degrade chemically, completely. And as a result of that, the connection between the nerve and the muscle, the neuromuscular junction, will also be degraded. And as a result of that, there will be actually muscle atrophy. Okay? So this is actually the second from the top, the Wallerian degeneration. Now, third from the top is the segmental demyelination. Segmental demyelination. So what is that? In this reaction, we see actually that the axon remains intact, okay? But the myelin is the one that is disintegrating, okay? So some of the myelin sheaths are still present, as you can see here, but some of them, are being, are breaking down. All right, so as a result of that, the nerve conduction velocity decreases and the neurological function is lost. But you could see here that the rest of the axon is still in touch with the muscle. So it remains connected with the muscle. And as a result of that, there is no muscle atrophy in this, specific reaction, in peripheral neuropathy. So with segmental demyelination, the muscles do not go on to have atrophy, to become atrophic. All right, so the bottom picture illustrates, and I apologize for the cutting. This is a picture I took from one of the places where, I found the different sources for this lecture. So, what's written here is distal axonopathy distal axonopathy, also known as axonal dystrophy. Okay? So what do you have here? So there is axonal degeneration that is happening in this picture right here, in the last one here. So it is truly actually related to the axon itself. Okay? But not just the axon and the myelin are becoming actually, degenerated. So both of them are becoming degenerated. So in a way, if you think about it, it is really similar to what happened with Wallerian degeneration, even though the etiology is different. Here it is transection. Here we will see exactly, how it comes to happen. Okay. So the difference between them, between the Wallerian degeneration and the axonal degeneration, is that one is resulting from transection. The second one is actually resulting from neuronal body problem. It results really, the underlying etiology in this case is going to be that, the neuronal body is unable to keep up with the metabolic needs of the neurons. I was thinking actually to give you an example of that, and if you recall actually from the POD, which probably by now is a distant memory for you, if you recall that we have talked in when it comes to the heart, that when there is an artery that becomes plugged, the areas that are mostly going to be affected with this first are going to be the area which are the most distal away from the origin of that artery. Remember that, the subendocardial region, with regard to the coronaries of the coronary artery of the blood, when it becomes, blocked. Similar exact thing here, actually. So here, the first area that is going to become degenerated after the neuronal body injury is going to be the most distal area from the origin, from the neuronal body. Okay, and similarly, as a result of the fact that it is the distal region that is affected, the contact between the muscle and the nerve is going to be affected. The neuromuscular junction is going to be degraded. And as a result of that, you can see that the muscles are, again, becoming atrophic. Okay? So this is actually the 4 different reactions, which I believe really, in a nutshell, what you should really focus on. When it comes to the specific diseases, we will see that, this is going to come later. And once you know actually the prototype, the example becomes easy. Okay? So with this introduction, let us examine with some details what happened, during these reactions. Okay? Starting with, sorry. What's happening here? All right, I guess only one function to move it. All right, so this is the basic reactions seen in peripheral neuropathies. All right, so starting with the Wallerian degeneration. So if you think about the Wallerian degeneration, it is perceived as an experimental model or example, if you will, of axonotomy, of cutting of a nerve, if you will. So you see it actually with transection, cutting, you see it with cooling, you see it with infarction of the peripheral nerve and other physical injury of the peripheral nerve, as example of causes of Wallerian degeneration. So in Wallerian degeneration, the proximal stump of the nerve will degenerate up to the node of Ranvier that immediately is proximal to the transection. Whereas the distal section disintegrates structurally and is degraded chemically in its entirety, as you can see here, including the neuromuscular junction and resulting in muscular atrophy. All right. So the axon and the myelin starts to regenerate slowly from the proximal stump, and eventually, actually, theoretically speaking, that the axon and the myelin should be able to give rise actually to a regeneration. But of course, we know that this is only theoretically, and the reason why it is theoretical is because it is infinitely, and the word is emphasized here, infinitely slow. So for all practical purposes, it will never happen. It will never heal. This is why they tell you that actually, a neural injury is final. There is no coming back from it. Okay? And that's the reason. So in theory, there is a chance, but in reality, there is not. All right. So slowly, the bottom now in the bottom picture here that you are looking at is actually a um, a peripheral nerve that is affected with Wallerian degeneration, and the nerve is stained for myelin. And you can see actually that this stain is showing that the myelin has broken into bits and pieces. Instead of a continuous kind of structure, you see that it has broken down into degraded, if you will, into bits and pieces. Okay. Now the top picture is fat. Actually, this is oil red O stain, and that's important to remember because when you do when if you want to think about why you're using fat in this case, when the myelin is 70% lipid and 30% protein. And as a result, actually, of the degradation of the myelin in this picture here, you see that there are a lot of fat that is stained with this, red color, resulting from the simply, the degradation and the breakdown of the fat that makes up that myelin. All right, so let's see, 1 second, please. Which one? I have a technical difficulty. Amazing, nothing. All right. All right. So again, Wallerian degeneration. If you look at this picture right here, what you're looking at actually is is four motor neurons in the anterior horn of the spinal cord. Okay, 1, 2, 3, and 4. Okay. Now, three of those neurons have large blue granules. All right. Those large blue granules are actually clusters of rough endoplasmic reticulum. Now, the fourth neuron, is enlarged and has a homogeneous appearance as opposed to this, neurons. This one has homogeneous appearance, and you see that the nucleus is pushed to the side of this neuron. This actually is called central chromatolysis. And the way to think about central chromatolysis is that it's a cluster of rough endoplasmic reticulum that become disaggregated and dispersed. And you should not think about it as degeneration, but rather it is exactly the opposite, because this is a revved up rough endoplasmic reticulum that is producing protein over time that is needed to regenerate the axon. Okay? So in a way, it is what you call a repair kind of appearance. Even though the name itself may imply otherwise, central chromatolysis, what's happening here is that actually the rough endoplasmic reticulum is simply, working overtime to produce protein that is going to be made, for the, recovery of the transected axon. Now, as long as the structural continuity is maintained between the proximal and the distal end, if you can see the arrow right here, as long as the structural continuity is maintained between the proximal and the distal stumps of the transected nerve, regeneration of the axon will follow the fibrous scaffold. There is a fibrous scaffold that surrounds actually this nerve. So the regeneration is going to follow the fibrous scaffold in an organized way, again, theoretically speaking, to its destination. But if the fibrous scaffold is destroyed, so if this actually becomes destroyed, the fibrous scaffold that is surrounding this nerve fiber is going to become destroyed, the end result is going to be the regeneration of those, neural fibers are going to become haphazardly arranged, resulting in the formation of what is known as a traumatic neuroma. And in this one here, in the bottom picture in this slide, you see the haphazard arrangement. You no longer have this very linear, very organized kind of arrangement of this longitudinal, section of this nerve, of this peripheral nerve. Rather, you start to have circular. You start to have, fragments, of these, regenerated nerves, being placed in all different directions, resulting in what is known as a traumatic neuroma. Okay. Once again. All right, so okay, so now we have done Wallerian degeneration. Let's see what's going to be in the next one. Okay, now the distal axonopathy. The distal axonopathy. This is what we have talked about, what's also known as the axonal dystrophy, and that is related to neuronal body degeneration, as you can see here. Okay, so now what's happening is that, as I mentioned to you, think about it as the most distal part of this structure is going to be affected because the source, the origin, is affected, first. Okay. All right. So in a way, actually, what you're going to be finding is that the pathological changes in the individual nerve fiber that are seen with distal axonopathy is similar to those, seen in Wallerian degeneration. Why? Because we do see that the myelin and the axon are becoming degenerated, at the same time. Now, the main difference is that actually the connective tissue scaffold of the nerve is maintained right here. Okay, whereas with the transection, that may not be the case all the time. Okay. Now, there is another name for distal axonopathy. They call it actually dying back. Believe it or not, they call it dying back, in that the pathology begins distally and spreads proximally towards the origin. All right. Again, similar to what you see with the POD, with the example I gave you, about the POD. Now, those neuropathies that will result from distal axonopathy are actually bilateral and symmetric. And because they are more severe distally, they cause stocking glove, sensory loss, and weakness. Stocking glove, it's like wearing a glove because it's going to affect the full, actually, distal part of that, of the nerve. All right. So we did talk about actually the cause of the distal axonopathy, and that is primarily a disease of the neuronal body, which through its metabolic abilities maintain the axon. When this is not the case, the first part that's going to disintegrate is going to be the most distal part of that, of that axon. All right. And that's actually the distal axonopathy. Remember that, dying back, because it starts from all the way from the distal and spreads backward towards the origin. This stocking glove, because it does actually affect, because it does affect the distal part very severely. Okay, and as a result of that, it will be called stocking glove, sensory loss, and weakness. All right. All right. Now, segmental demyelination. As I mentioned to you here, what's happening, it's a problem in this case of the myelin, because the axon, more or less is intact. What's happening is the myelin that is getting lost. All right. But because the axon and the neuromuscular junction are still intact, the muscles are maintained. The muscle will not suffer from atrophy in this case. However, the conduction velocity, are going to slow down, and this may cause weakness or paralysis and sensory loss. Now, the myelin is lost, but the Schwann cell is still there, are still intact. And as such, they can repair this lost myelin segment. This is why recovery from segmented neuropathy is more complete than Wallerian degeneration and more rapid. All right? So, now you're starting to see actually the difference between those. In this case, you will see that the repair, that the recovery from a segmented demyelination is going to be complete and rapid. Why? Because the axon is fine. The axon is not really the problem. It is the myelin, but the Schwann cells are still there, are still fine. So as a result of that, they could give rise actually to more of this myelin, which is simply really the Schwann cell membrane, as we have talked about in the earlier, slides. And the end result is going to be that, there will be recovery pretty quickly. All right. So if you take a look at this picture right here, so the upper left is normal. All of those actually nerves are, myelinated nerve, myelinated axon in this case. Now, if you took a look at this picture right here, this is actually severe, diminution of the myelin. Myelin is simply gone, so that was surrounding those, axons. So much so actually that in this axon, you start to see that the myelin, this is an electron microscopy, these dark dots are remnants of the myelin sheaths that used to be here. Okay? So the dark dots are simply fragments of the myelin sheaths that used to encase this axon. All right, so you will see that in the early stages of repair, you will see that the myelin sheath is going to be thin, as you can see here, and as you can see here. All right, and then as time goes by, it will thickens, progressively, eventually giving rise to a full, normal thickness of the myelin sheath, as you see here. All right. Excuse me, into a full mature myelin sheath. Okay. Now, if you look at this picture that we have just talked about, actually, you are going to be seeing that it's a composite, composite picture that has everything that you need to know about, the demyelination that is happening in segmental demyelination. So there are actually, in this picture, you will see in the left corner, you will see this axon with the thick myelin sheath. In the right upper corner, you will see axons with thin myelin sheath. Now, in the left upper corner, right here, as you can see here, you look at the sheath of those axons, and they are nowhere to be found actually. So you see the unmyelinated, or I'm sorry, the demyelinated, and you see the thinly myelinated, and you see the normal myelination of this axon in one picture. A nice picture. All right. So we have talked about the basic patterns, if you will, that you see with peripheral neuropathy. Now let's talk a little bit about. Let's talk about. Sorry. All right. Let's talk about some of the causes. Just to start. To turn it clinically a little bit from the beginning. So diabetes is actually a big number when it comes to cause, of peripheral neuropathy. All right, and the number of people with diabetes, this is actually wrong. I apologize. It's up to 40% actually. Up to 40%, up to 50% of people above 55 years of age have peripheral neuropathy. So that's a very high number actually when it comes to incidence of this disease in patients with with diabetes. Especially long-standing diabetics, up to 50%, half of them actually have the peripheral neuropathy. Now, 12% of the 8 patients also may have the same, may have neuropathy. They will have different forms of neuropathy. There are also some genetic actually causes of the disease, such as Charcot-Marie tooth disease, the CMT disease. It's due to a mutation in one gene known as PMP, and it presents itself with polyneuropathy. It's a pretty rare condition. 15 to 20 in 100,000. That's actually compared to the frequency of the hereditary polyneuropathy overall, which is about 30. And then actually the incidence of GBS, the Guillain-Barré syndrome, which is the most common demyelinating polyneuropathy, is 0.4 to 1.7. So you would think, why should we talk about GBS and not talk, for example, about, the Charcot-Marie tooth disease? Well, GBS is actually a medical emergency. We'll talk about it in a little bit of detail in the next few slides. All right, it is the most common inflammatory demyelinating polyneuropathy overall. That is GBS. All right, so approach to a patient with peripheral neuropathy. What do you need to actually, how do you think about a patient who's presenting to you with this condition? How would you come to a diagnosis? How would you be able to split, if you will, the diagnosis to reach at least a working diagnosis of what the patient may be having? So the questions that you need to entertain are the following. First, is there such a disease or not? Is there a neuropathy or not? Secondly, you have to talk about actually, or you have to think about what kind of neuropathy is it? Is it a mononeuropathy involving one nerve, or involving asymmetrical or few asymmetrical nerves, or is it polyneuropathy involving symmetrical kind of involvement of nerves, in throughout the body, or throughout the limbs, for example? Uh, is it axonal or demyelinating neuropathy? Is it active or is it burned out? And what's causing it? Now, the first four questions are actually the easy part of this approach, if you will. The cause is really what's proven to be difficult. The reason for this is that different peripheral neuropathies usually present with similar clinical, with similar pathology. So even pathology, even a nerve biopsy, is not going to nail it for you. Is not going to give you the final diagnosis on its own. So this is why you have to combine actually, the clinical workup of the patient. You have to look at the pathology, both tissue and serum. For example, you may do serologic work on the CSF on the patient to look at the protein level of those patients. For example, it is known that GBS patient, Guillain-Barré syndrome patients, have higher levels of protein in their CSF. All right, and you need also to do some special lab tests, including nerve conduction test, and also including EMG to rule out any muscle cause of the presentation. You may do also some, if you are still are not sure if you're dealing with a neural versus a muscle disorder. You may do the muscle enzymes such as CK, creatine kinase, with which actually after a certain level, you are going to be assured that you have, for example, a muscle kind of disorder. It becomes really high level. And this you have to add, and you have to look at it as as a integrated kind of diagnosis. So one shot is not enough. You have to look at several pieces of the puzzle in order to reach the diagnosis. So let's talk about each question one by one. Okay, starting with all right. All right, so now, patient presenting to you with peripheral neuropathy will present with weakness, atrophic muscle sensory abnormalities, or loss and weak and absent tendon reflexes. So most of the presentation that you are going to be getting, hello? Yes? Hello? Is there anybody want to say something here? Yes, hello?
No, doctor, I think that was a mistake.
All right, so it was just like maybe. Let's hope it's not a hacker, okay? All right, so let's talk about the approach to this. So most of the time, actually, those who will present to you with peripheral neuropathies are going to be presenting with mixed picture, both motor and sensory. Now, there are times when you have only, one of those. For example, if you have only motor kind of presentation in a patient, who's presenting with peripheral neuropathy, think about GBS, Guillain-Barré syndrome, which is the most common demyelinating polyneuropathy. Something to keep in mind, and it's very important actually to keep that diagnosis on top of your list, especially if you are having actually a patient who's presenting with, primarily a motor deficit. The reason for this is that you may actually save the patient's life, with your prompt diagnosis. GBS, it could be a very uh, progressive on a very short, very short, time frame, simply resulting in respiratory paralysis in just a few hours and killing the patient as a result of that if you don't actually pin the diagnosis of that patient. All right, but again, most of the presentation is going to be, with a mixed actually picture, mixed bag, if you will, sensory and and motor. So yeah, all right. Okay, so this is actually as a first. All right, so if it is a neuropathy, the question that is going to come next is going to be, what kind of neuropathy are you dealing with? Is it axonal, or is it demyelinating? And the reason for this is that, even though there is unfortunately little that you could do, but you still actually need to know if it's a GBS, because with GBS there is a support, intervention that you have to take. So in a way, you're trying to cover all your bases by reaching actually the diagnosis and ruling out the most important of them, to ensure that your patient will stay safe. All right. So after the physical diagnosis, physical exam, you have determined that your patient have peripheral neuropathy. The question now, is it axonal or demyelinating? So most neuropathies are actually going to be axonal, and most commonly caused by distal axonopathy, and less frequently by the transection Wallerian degeneration. All right. So most of the time it is going to be distal axonopathy. So most of the time it's going to be related to the neuronal body disease. And the axonal ones, especially the distal axonal ones, evolve in a slow pace, except when it is related to vasculitis, where it becomes, faster than that pace, but still, way less than what you see, for example, with GPS. Now, those patients who have actually the distal axonopathies are going to have incomplete recovery. So incomplete recovery and a slow recovery at the same time. It's gonna take forever, if any, kind of recovery to happen for those patients. On the other hand, the demyelination neuropathy, they are going to appear and they are going to evolve rapidly, sometimes within days or even hours. And they have, at the same time, they have a faster and more complete recovery, which is, again, I mean, that's pretty good, but it can kill someone if it is a GBS that has involved the respiratory muscles, resulting in respiratory failure. Okay. Now, there are additional clues that could be obtained from the nerve conduction studies and EMG. And those are going to show low conduction velocity or conduction block in demyelinating neuropathies, and low action potential amplitude in axonal neuropathies. So the nerve conduction studies and EMG are going to also help you reach actually a diagnosis between axonal versus demyelinating neuropathies. All right. Okay, finally it's working now. All right. So another important distinction to make is going to figure out if it's a mononeuropathy versus polyneuropathy. Is it affecting a single nerve, resulting, for example, in a foot drops, okay, versus diffuse, symmetrical polyneuropathy. So the mononeuropathy will affect, as I mentioned to you, a single nerve or a few nerve, few nerves asymmetrically, not symmetrically. Okay. And the mononeuropathy is usually actually axonal neuropathy, most commonly caused by vasculitis. Symmetrical polyneuropathy is much more common than a single nerve involvement. Okay? And symmetrical polyneuropathy will be divided between axonal, which is most commonly caused also by diabetes or toxin and drugs, and demyelinating polyneuropathy, most commonly by autoimmune inflammation in the peripheral nerves. All right. Now, another important distinction is going to be between acute versus chronic. Acute onset versus chronic. So with the acute onset high on your list, number one on your list should be actually the GBS, the Guillain-Barré syndrome. This is number one. And also neuropathy caused by vasculitis. Most other neuropathies are going to be actually chronic. Now, the clinical exam will distinguish, for you, one more. Just 1 second, please. Yes. The clinical exam is going to distinguish for you between large versus small axon involvement. Why is that? Because the large axon are involved in weakness, loss of vibration and position sense, so motor, loss of